questions instead of Dr. Kuntavi. Okay.
Just give me a minute.
Sanjeev sir has joined. First speaker has joined.
Good evening, ma'am. Good evening, sir. Good evening, everyone.
Sir, shall we start?
Yes, please.
Yes.
Go ahead.
We'll start with Ganesh Vandana, then ESI song, and straight away we'll go to the program.
Absolutely.
Jignesh, can you play it?
Om Gangadapataye Namo Namah Shri Siddhi Vinayak Namo Namah Ashtavinayak Namo Namah Ganpati Bappa Moria
Om Gangadapataye Namo Namah Shri Siddhi Vinayak Namo Namah Ashtavinayak Namo Namah Ganpati Bappa Moria
Om Gangadapataye Namo Namah Shri Siddhi Vinayak Namo Namah Ashtavinayak Namo Namah Ganpati Bappa Moria
Now can we have the ESI anthem?
We shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe we shall overcome someday. We shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe we shall overcome someday. We walk hand in hand, we walk hand in hand, we walk hand in hand someday. Oh, deep in my heart, I do believe we shall overcome someday. We walk hand in hand, we walk hand in hand, we walk hand in hand someday. Oh, deep in my heart, I do believe we shall overcome someday.
Thank you. And can we have the slides of the chairpersons? Good evening, everyone. It's my great privilege and honor in introducing Dr. Sudha Singh ma'am, an esteemed senior academician and clinician known for her vast experience and valuable
Science, money, it's very, very money. Come on, freeze for the presentation.
Dr. Sudha Singh, ma'am. She's a director and senior consultant, Shubham Mother and Care, Shubham Fertility Center, Chandrika Nagar. She's MBBS, MD, OG, IMS, BHU, past president of VOGS, North Zone Coordinator, Endometriosis Society, India, 2023 to 2025. President, Varanasi branch of Indian Menopause Society, 2023 to 2025. She's practicing consultant for infertility, ART, endoscopy, high-risk pregnancy. She's life membership of FOXY, IAGE, ISAR, IFS, IMS, ESI, IMA, and INTACH. A heartfelt welcome to you, ma'am.
Thank you.
Can I have? And it is also my great privilege and honor to introduce our respected chairperson, Dr. Ramani Devi, ma'am, a name that needs no introduction in the field of endometriosis. Her contribution towards advanced gynecological surgery, academics, and mentorship has inspired countless students, including me and clinicians. Her passion, precision, and dedication towards women's health continue to set a benchmark. So, ma'am is the president of TNFOG 2024, National Vice President Foxy 2020, ICOG of Governing Council Member 2018 to 20, Managing Director of Ramakrishna Medical Center, Janani Fertility Center at Trichy and Pattukotte. She's chairperson of Endometriosis Committee of Foxy 2014 to 2016.
Ashwini, we'll move on
Yes,
to
ma'am.
the next one. Okay.
Yes, okay, ma'am. On behalf of the organizing team, I extend a heartfelt welcome for both of our respected chairperson, and thank you for chairing the session with your presence. Over to Ramani ma'am and Sudha Singh ma'am. Kindly introduce our speakers, ma'am.
The first topic will be by Dr. Sanjeev Kaur. Okay, Dr. Sanjeev Kaur is a very senior infertility and IVF consultant from Pune who has been practicing there for more than 40 years, and he was the president of Pune Society, coordinator of West Zone for Endometriosis Committee, FOXY, and he established the Pune's first super specialty infertility center along with Dr. Sadhana Kaur, he is also a gold medalist, and he was awarded the Foxy Young Scientist Award by Foxy at the World Conference in Infertility held in Singapore and Bali, Indonesia. And he has got original scientific contributions. And to say a few, he has developed the Kurtz technique of tubal ligation device for reversibility and the peritoneal jelly sign. What we see in all pelvic endometriosis is named after Kurtz peritoneal jelly, and the spotted ear sign is a new diagnostic sign for PCOS in hysteroscopy. So all the scientific contributions and presentations were presented, and he received distinguished awards at various national and international conferences. Along with Dr. Sadhana, he has released a book on polycystic ovaries, the thief of womanhood. And he is a very good friend of mine, and I am very much privileged to have him today to give his talk on why women are infertile. Sudha madam, would you like to say a few words about the infertility before Dr. Sanjeev Kaur is ready with his presentation?
Good evening, everyone. Infertility is around 15% every year, but with the changing scenario, late marriages and not wanting to have kids and being career-oriented, infertility has become a big issue now. And when I started my practice, we in the northern part of India, we hardly ever saw endometriosis. And now it is as bad as in Kerala, not because changing food styles and infertility, and there's so much pressure on career that people have forgotten to look after their infertility and womanhood. So I think we should all, today we'll be talking about infertility from the expert, and we need to orient people to learn to have pregnancies at the right time at right. Thank you so much. And I welcome Dr. Sanjeev Kaur for his.
Thank you. Thank you, both Dr. Ramani Devi and Sudha Madam. It's indeed a pleasure to be a part of this wonderful series of webinars focusing on endometriosis, which is dear to Madam your heart. I'm very much aware about it. And it's a privilege to give and share my little bit of experiences about the topic. Uh, are you able to see the slides, madam? Hello?
Yes.
Oh,
Yeah,
that's
yeah.
It's fine.
Oh, that's fine. Correct. So thank you again. I bring you greetings from Pune and our IVF center, and especially Dr. Sadhna and Aditya, who have been a part of this whole journey of endometriosis. Well, we all are aware that there is what we call as severe endometriosis, where the both tubes are adherent, they are blocked, and we understand very clearly what is the reason for infertility in this woman. But the problem comes whenever we see minimal endometriosis. And then we wonder everything is fine except for these tiny spots. So how come these can cause infertility? And also, as madam, you mentioned about the jelly sign. Now this is something that we all see at laparoscopy or maybe at laparotomy. In pouch of Douglas, you see this jelly masses. In fact, I was curious, and then I started biopsying these jellies. So we all have seen these jelly masses, and I was curious. And then I started biopsying them, and I realized my pathologist told me that they contain endometrial glands and stroma. So that means presence of these glands and stroma outside its normal location, the uterine cavity. So that is endometriosis. And we presented this research at the Copenhagen World Conference in 1997. Now, what is again interesting to note that in 5% of cases, the jelly was the only sign. And then one wonders that when minimal and mild endometriosis is there, how come these women have infertility? So what makes these women suffer infertility when you have such minimal signs? Well, William Osler, more than 100 years ago, mentioned that he who knows gynecology. So that means the knowledge about endometriosis was much far less. But in 100 years, has anything changed? But not much, I would say. Robert Shaw mentioned that endometriosis is a benign, estrogen-dependent progressive gynecological disease in women of reproductive age. Yet, however, there is much that is still not understood, and the condition still arouses interest and controversies. I'm sure in 1926, he would have said the same thing. So, in spite of endometrium being the enigma, let's try to understand why women are infertile when they suffer from endometriosis. Well, John Sampson had mentioned that it is endometrium-like tissue, which is outside its normal location. And what is interesting that it is pathologic, and this tissue not only is just there, but it must persist and progress to cause problems about this disease. Now, actually, does endometriosis cause infertility? I'll just take you to some statistics which we are all aware. It's a disease of women of the reproductive age, present in about 10 to 20% of women. Not every woman with endometriosis will experience infertility. That is something that we must understand. 30 to 50%, well, various studies have mentioned, of women with endometriosis will. And the incidence of endometriosis ranges from 20 to 50% in infertile women in various studies. So this means there is some relation between the two, and what we do not know the exact mechanisms, which remain unclear. Just like I mentioned to you, just minimal endometriosis. The jelly is there. That's the only sign of endometriosis, and we don't know how come this lady is infertile. Endometriosis causes fertility. That is what exactly has been observed over ages. Now, these are old studies in 1970s and 80s. So how did they diagnose endometriosis? They did a laparoscopy. They found the telltale signs of endometriosis, and they said this lady is suffering from endometriosis. What did they do? They did nothing. So these were cases of mild endometriosis, stage 1, stage 2. They did nothing. And what did they find? That nearly half of them conceived. Remember, normally one would have expected, had these women been normal, nearly 85-90% should have had pregnancies. It did not happen. So that means the pregnancy rate is less. And when they quantified it, we all very well understand from the normal 15, 20, 25% per month, it crashes down to as low as say 1%, 2%, 5%, at the most 10%. So that means the pregnancy success every month is reduced. Now, we have understood that endometriosis at all stages has a negative impact on fertility. it causes subfertility. And most important, as there is advancement in the stage, for stage 1 and 2, it's just 50%. Stage 3, lower to 33%. Stage 4, well, hardly 0 to 3%. So this means more severe the disease, lesser is the fecundity. That is exactly what we must understand. Now, how does endometriosis cause subfertility? Endometriosis affects all stages of reproduction, leading to subfertility, which causes infertility. Well, we all know about endometriosis disease of theories, various theories, right from John Sampson's retrograde menstruation to vascular and lymphatic spread, stem cells, immunology. So many theories have been propounded. But most important, that the cause of infertility, I would say, most important is the chronic pelvic inflammation. And then we have other causes also, fibrosis, which causes anatomical distortion. Pain, when there is dyspareunia, the sexual dysfunction goes down and the couple may not be able to have normal sexual relations, therefore suffer from infertility. Endocrine dysfunction. And today now we understand there are molecular dysfunction also. So all these put together are causes of infertility in this women with endometriosis. As I mentioned to you, but I feel one of the most important reason is the hostile peritoneal environment. Various cytotoxic metabolites, substances are produced by the endometriotic implants or the surrounding tissue. Icosanoids, prostaglandins, inflammatory cytokines, there are various. Interleukin-1, beta, interleukin-8, interleukin-6, TNF-alpha. All these attract macrophages, interleukin-8 and vascular endothelial growth factors and cause the problem. The studies have shown there is an increased production of all these in the peritoneal fluids and sera in women who have endometriosis. And what we must understand that endometriosis causes a pro-inflammatory environment, which is the cause for subsequent changes that we see. These elevated inflammatory cytokines and activated macrophages lead to decrease in the oocyte quality because of oxidative stress and higher rates of spindle abnormalities. The sperm is affected. The increased sperm DNA damage, reduced sperm motility, acrosomal reactivity, therefore penetration is diminished and therefore fertilization suffers. Embryo quality is also compromised. Embryo cleavage is reduced and slow embryo development happens. Now, the inflammatory environment causes altered defective folliculogenesis. There's luteinized unruptured follicle syndrome, and most important, there's progesterone resistance. All this prevents a successful ovulation and also causes luteal phase defect, which is the cause for infertility. Now, people talk about progesterone resistance. Now, what is it? Now, endometriotic lesions have produced high levels of inflammatory cytokines, which we saw, and this leads to silencing of the progesterone receptor gene through DNA methylation, causing imbalance in the production of progesterone receptor isoforms. There are two isoforms, progesterone receptor A and progesterone receptor B. Now, progesterone receptor B is often severely downregulated or absent. Now, what is the significance of these receptors? Now, this slide clearly shows you whenever there is a healthy normal endometrium, it is the progesterone receptor B that is in action. It decreases the cell production which occurs because of estrogen, desudilation, apoptosis. It has an anti-inflammatory effect and anti-angiogenic effect. But what happens in women with endometriosis, the progesterone resistance, there is an imbalance in progesterone receptor, these isoforms, A and B. The B, which is an important thing in healthy endometrium, is severely downregulated or absent. And therefore, what happens is the estrogen action goes unabated. There's increased cell proliferation, impaired desudilation, reduced apoptosis, reduced anti-inflammatory effect, and increase in angiogenesis. And this is the reason the progesterone resistance effect sets in. Now, in women with endometriosis, unlike pelvic inflammatory disease, tubes are rarely affected and show patency, even in stage 4 or severe endometriosis. But what really happens is anatomical distortion that can happen, which causes the fertility to reduce. The adhesions and fibrosis in the pelvic distort the tubo-ovarian relationship for ovum pickup. And of course, when the tubes are affected, there is terminal tubal block, it causes hydrosalpinx. Obviously, this woman is bound to have infertility. Now, as I mentioned, it affects all stages of endometriosis, including implantation. But if you go back 25 years ago, it was believed that endometriosis does not affect implantation. Implantation is affected because of this poor embryo quality. This is from Dr. Pellicer's study 30 years ago. Then endometrial receptivity, the pinopod expression is unaffected. That is what Garcia Velasco had said. And in egg donation program, remember, the woman who has endometriosis, the success rates are unaffected. So all this led to believe that probably endometriosis affects all other stages except implantation. But that is not true. That is what we see from the recent molecular dysfunctions. We have very well understand the HOXA10 is an important key marker during the implantation window, and failure to express has been seen in these women who have endometriosis, and therefore that prevents successful implantation. So to sum up, endometriosis is a I would say, or pro-inflammatory, causes pro-inflammatory environment. And because of this pro-inflammatory environment, various other steps of human reproduction are affected. And this leads to decrease in per cycle of pregnancy rate from the normal 15, 20, 25%, which happens in a fertile woman. It crashes down to as low as 1 to 10%. And of course, when the tubes are blocked, it is 0. So endometriosis is subfertility. And therefore, all efforts are aimed at improving or increasing this chance of lower success by reducing the pro-inflammatory environment. So therefore, when you do surgery and debulk, the cytokines come down. And of course, then we take, in addition to that, we take recourse to assisted reproductive technology in form of either intrauterine insemination or an IVF. So I hope I've been able to put forth why these women with endometriosis have infertility. So thank you very much. Any comments, madam? Dr. Ramani Devi? Dr. Sudha, madam?
Do you think uterine contractions also have a role in endometriosis for preventing of implantation?
Madam, I'm not sure about that, but probably since there is inflammation, it could. Yes. But when you list out, when you see the textbooks, the mention about these uterine contractions, I'm not sure whether I really went across to it. But yes, I would agree with you. See, an inflammation is something that is going to affect, well, every step in physiology.
Sir, we can also explain this way, sir, because most of the patients with endometriosis and infertility, around 30% of the patient and even beyond, they have adenomyosis. So that is one reason where there is implantation failure because of the improper HOXA and FOXA gene, and also the endomyometric junction, which is very much widened. So that could be another reason where there can be increased myometrial contraction. Again, you have beautifully explained about the anatomical reason, then the pro-inflammatory causes, then the endocrine causes, and even you have clearly explained all those things. So, per cycle consumption in infertile endometriotic patient is very, very low. That is, the fecundity rate is only 2 to 3. But whereas upon treatment, upon modulating correcting the anatomy, correcting the pro-inflammatory status by suppressing with GnRH analog, and that will all improve the outcome of the pregnancy, as well as we can add up some assisted reproductive technology, because since the natural conception is there, assisted reproductive technology can definitely improve the outcome of fertility, sir.
Yes. Madam, I just have been pondering that women with even severe endometriosis,
Yes.
We have seen them conceiving spontaneously. Am I
Yes,
right?
sir. So that is
Yes,
all.
Dr. Pradeep, I'm sure you will agree with me.
Yes, sir. We
I've
have
always
seen a lot of
wondered-
patients who have had multiple IVF failures. They
Yes.
conceive spontaneously.
Yes.
So probably the stress is one thing that we have to take up, and probably that is the reaction of the drugs what they have been put on during the treatment cycle. That also has some effect, I personally feel, and more and everything. It is a stress factor that is taken off, sir.
Yes.
So then that is why they say the natural fecundity is around 2 to 3 compared to 10 to 15% in non-endometriotic patients.
I agree. No, but I was just thinking loud to myself that this particular lady who has severe endometriosis did not conceive all these years and spontaneously she conceives. Now, how
Yes.
come this must be happening? My only thought, you may probably dilate upon it, that see, the thing is, whenever there is inflammation, body always tries to heal. Always tries to heal means bring down the levels of cytokines.
Yes.
See, that in that healing process, it could happen in a particular uh, frame of time, the cytokine levels drop down to so low, which created an environment where she conceived.
Yes.
That's the only explanation which probably I'm sure you would have been thinking
Yes, yes, sir.
on
Definitely.
some other lines also. I'm not so yes. And our drugs that we use brings down the levels of cytokines and creates an
Definitely.
environment which is congenial for natural conception
Exactly.
or with assistance. Yes.
So the concepts regarding the fertility, infertility reasons are changing. And you have rightly pointed out the progesterone receptor resistance. That is
Yes.
especially the progesterone B isoform, which is highly downregulated, and the correction that is possible nowadays. In future, we'll be able to identify which are the receptors particularly which are dysregulated, and you can correct it. And probably these are the reasons why these patients, they need a high luteal support later also.
Very true. Very true.
They need definitely a higher luteal support than
Yes.
a patient who has got a tubal block or a male factor. I think Dr. Sudha madam also will agree with me.
Yes, yes, ma'am.
One important area most often we miss, that is associated adenomyosis. We do surgery for endometrioma, we do surgery for DIE and everything, but we miss out this adenomyotic component, and later only this part is the cause of subfertility.
Very true.
Very true, sir.
Yes.
And another thing, as Sanjeev was highlighting, this natural conception suddenly it occurs. We don't know. We even don't know. In a very severe endometriosis case, we just lost all the hopes, everything. All of a sudden, shake him up with a normal pregnancy, just normal conception, and just went on it. Highly valuable pregnancy category case, and went ahead. There is a scenario. So as you say, that part is very true. That might be this altered environmental milieu, particularly this microenvironment, which at threshold level comes at sometime, and that might be the reason of this unexplained spontaneous pregnancies.
Okay, great. Thank you, Dr. Pradeep. Yes.
Nice introduction, Sanjeev.
Yeah.
Excellent.
Very
Pleasure
nice.
meeting you at least virtually.
No, I'll speak to you later.
Yeah, sure.
If you don't mind, I'll be meeting you over phone within a couple of days.
Sure. Take it. Thank you, Madam Dr. Ramani, Dr. Sudha, Dr. Pradeep. It was a pleasure. Thank you.
Very nice presentation.
Thank you very much, sir, for accepting
Yes,
our
yes.
invitation and giving a very crisp and a very nice talk.
Always a pleasure, madam, to be a part of your wonderful program. I enjoy, and the other speakers also have been excellent. The earlier webinars have been fabulous.
Thank you, sir. Thank you. So, Harshini, shall we move on to the next talk? Sir, you can stop sharing your presentation, sir.
Okay.
Okay, thank you.
Yeah.
Harshini, where are you? Okay, if she is not there, the next talk will be, instead of Dr. Kundavi, I am going to give the talk on IUI in endometriosis. So, sir has so far mentioned what are all the, just 1 minute, causes for infertility, but now, sorry, 1 second. So today, actually, Dr. Kundavi was supposed to talk, but since she is not well, I am going to talk on behalf of her. One second. Is my slides visible?
Yeah.
Okay. So does IUI work with endometriosis? Sir has very clearly explained about the reasons for infertility in endometriosis. Now the next question is how we are going to overcome and give them a baby. So the basic pathophysiology I just explained in one slide. Various reasons are there to cause infertility. The main thing is a pro-inflammation that will harm the egg quality, and you have to accept that when they studied the regression in the AMH level or regression of the follicles in the endometriotic ovary when compared to the normal ovary, they found it was 23% higher decline in the eggs oocyte number and quality when compared to healthy one. And then there was abnormality of the sperm function. The sperm's function is abnormal, and there is improper fertilization, and the fertilization rate is all decreased. This is probably because of the macrophages which are found in a very high level in the peritoneal fluid, which will hamper the picking up of sperm function as well as picking up of the oocytes. So then again, there are distorted anatomy that can lead to adhesions, scar tissue, which may affect how the egg travels from ovary to the fallopian tube. And then there are endometriomas, which will reduce the ovarian reserve and response to stimulation also. Then again, there are a lot of implantation issues, as Sir has mentioned. There can be abnormal progesterone resistance, then there can be abnormal COXA10 and FOXA10 genes are all suppressed, which are needed for implantation and sterilization. So how the controlled ovarian hyperstimulation helps along with IUI helps in promoting the fertility. So this can improve the endocrine environment. It is again said there may be a background hyperprolactinemia and there may be altered FSH-LH ratio, which can produce abnormal folliculogenesis and hence an abnormal oocyte. So this can be corrected by ovulatory dysfunction can be corrected by controlled ovarian hyperstimulation, and then it can facilitate the sperm transport, and it has been used routinely in the management of infertility in women with endometriosis. So how to select the patient for IUI in endometriosis. So always it is better to select patients who are in minimal or mild stage, and the age should be less than 35, because beyond 35 years, then there is where there is declining of AMH level and where there is a poor ovarian reserve, they do not generally respond to controlled ovarian stimulation with IUI. So by doing this, you can improve the fertility to up to 10 to 15% per cycle. After this can be improved by controlled ovarian stimulation and IUI. Again, regarding the tubal function, at least one tube should be patent. That must be confirmed with any of the tubal patency tests. Then semen parameters, at least the minimal sperm count should be greater than 5 million per ml after preparation. Then the duration of infertility. It is often recommended for those women with less than 2 years of infertility. They can undergo IUI. Then the previous treatment. If the patient has undergone recent laparoscopic surgery to remove the endometriotic lesion, then immediately the patient should undergo IUI or IVF depending upon the endometriosis fertility index score. So generally nowadays we are of the opinion we don't go in for laparoscopic surgery for infertility unless the patient has got severe pain. So pain is the main indication to say that the patient needs surgery, and immediately simultaneously start treating the patient for fertility. So these are all the three available tubal patency tests, that is ICOG, where it is often recommended as the first line one. It is very safe and tolerated and ultrasound based, and we can also visualize the uterine cavity, ovarian morphology and tubal patency in a single session. Then comes the histosalpingography, which is commonly available everywhere, but the main thing is it can only identify the cavity as well as the patency of the tubes, but we cannot see the endometriotic lesions outside the reproductive organ. Then comes the laparoscopy, which is an ideal way to diagnose endometriosis, treat endometriosis, and simultaneously you can have a look inside the uterine cavity as well as chromoperturbation can. During laparoscopy, we can find out the patency of the tubes, but it is always, remember, it is invasive and typically reserved for when surgery is already planned, especially it is done in patients who are suspected to have endometriosis. For example, the patient would have been treated for many months for unexplained infertility. But if you want to find out the reason, maybe we go in for a laparoscopy, and if we find endometriotic spots, then it is the ideal way. Then one more thing is, as I said earlier, if the patient has got severe pain with endometriosis, then it is the only way to treat. So the comprehensive evaluation, this laparoscopy gives a comprehensive evaluation of the pelvic disease, and often this can also be achieved by a detailed transvaginal ultrasonography, MRI for deep infiltrated endometriosis and ovarian endometriomas. So now let us see the IUI, who should be chosen for IUI. And the first thing is the age. The age, if the patient age is less than 30 years, 15 to 20% they have a success per cycle. If the patient is between 30 to 35 years, 10 to 15% will be the success. Beyond 35 years, the success rate declines to less than 5 to 10%. So endometriosis plus age, it will have impact on IUI. Always a young patient with stage 1 and 2 endometriosis, they are the best candidates for IUI and they have very good success rates. But if the same patient is elderly, even for a mild to minimal to mild disease like stage 1 and stage 2, they have a lower success rate. Faster move to IVF is recommended in this patient. In severe endometriosis, IUI is not always effective. It is only the IVF that is needed regardless whether the patient is young or old. So IUI treatment strategy, how should you plan for IUI? So always go in for a superovulation and never do IUI without in a natural cycles, because in the natural cycle the results are very low. So combining IUI with stimulation medication, and the commonly used medication is letrozole, and always combine letrozole with gonadotropins, which is more effective than letrozole alone. So now the success rates, stimulated versus unstimulated. The stimulated IUI, that is controlled ovarian hyperstimulation with IUI, it gives a pregnancy rate which may be from 11 to 20% per cycle for minimal to mild endometriosis. In natural cycles, it is similar to that of the fertility rate in any endometriotic patients, only 2% per cycle. And cumulative success rate. One study, it was shown that 12 months cumulative pregnancy rate of 53.4% for surgical treatment combined with age and combined with stimulated IUI, significantly it improves the pregnancy outcome rather than surgery alone. So it is like this, the combination of drug treatment, COH, younger age group, mild to minimal to mild endometriosis, that will definitely improve the outcome, and maybe you can go in for a cumulative success rate. But the maximum of 6 cycles are alone accepted. That will cumulatively, that will give almost maybe 50% of the patients can conceive. So then the IUI cycles for minimal, mild to minimal thing, you can try how long you can try. So maximum of 3 to 4 cycles, and before considering more advanced treatments like IVF. If the patient is quite young, if her AMH is quite adequate, and if the tubes are patent, then probably we can try to go for IUI for 6 cycles. But whereas in patients who are crossed 35, in Indian scenario, I would say even beyond 32, the patients needs to have a shorter period of IUI cycle trial, that is less than around 2 to 3 cycles. Then if failing this, the patient should be straight away pushed to IVF. So basically, it is depending upon the age of the patient as well as the number of attempts and the AMH levels. So whether you want to go in for a single or a double IUI, this is always a dilemma, but there is no consensus in the literature prioritizing single or double IUI, but preferably double IUI is done in patients who have had a male factor. So the reported trend is better results with double controlled ovarian hyperstimulation with IUI. And we have also seen practically that we will decide that if the patient is not conceiving this cycle with the double IUI, maybe we will shift the patient to IVF. Then in that cycle, the patient can conceive. So again, what is the number of follicles you need for IUI? So the number of follicles are minimum 2 to maximum 3. More than 4, if there are mature follicles, then the chances of getting multiple pregnancy is quite high. So this was an article regarding the efficacy of IUI in women with endometrioma associated with subfertility. IUI may be a viable approach for subfertile women with endometrioma, and when no other identifiable factor for infertility is there. More studies are needed to reassure the finding. Ovarian endometriomas are often associated with lower positive pregnancy rates after IUI. So there was a study where they have found out if the patient has got a single factor like endometriosis alone with a normal male factor and a normal tubal factor, then her chances of getting a positive pregnancy in IUI is much better than multiple factors. So then the mild stage, it may be a viable option, and often you can get 5 to 10% success rate per cycle. In moderate to severe, there is no chance for spontaneous conception, may be exceptional, but after surgery, the patient can have up to 5%, very low rate of controlled ovarian stimulation with IUI can give very low positive result, but IVF frequently it is recommended as a most effective alternative. But we have to again accept that even in IUI, mild to moderate cases, they have a better outcome with ART rather than with severe endometriosis. Then there was another study, controlled ovarian hyperstimulation with IUI infertility associated with endometriosis. It was a retrospective study which shows that endometriosis did not affect clinical pregnancy rate per patient compared to other infertility factors. Endometriosis of various stages have no effect on success of controlled ovarian hyperstimulation combined with IUI. So, but often we know that definitely lower stages have got a better outcome. In moderate to severe endometriosis, IUI is not generally recommended because it can have distorted pelvic anatomy, lower success rates. Instead, you can go in for IVF straight away. Then coming to the deep infiltrative endometriosis, there is limited evidence for IUI benefit, and IVF is generally favored. But the recent studies show that if a patient gets operated for deep infiltrative endometriosis for compliance of pain, the chances of getting spontaneous conception is almost 50% over a period of 2 years. And after surgery also, if ART is done, the chances for conception is still better. So then again, there was a systematic analysis of pregnancy rates following IUI in moderate to severe endometriosis. This meta-analysis shows that IUI is a feasible treatment in moderate to severe endometriosis. Whether this treatment should be structured but prior to IVF needs to be investigated in a randomized control layer, including time to pregnancy, safety, and cost effectiveness. Definitely, we know that IUI is a less invasive, less costly procedure than compared to ART, but whether it is going to be of use in moderate to severe endometriosis is a $1 million question, but probably we can try this because still it has got success of about 10 to 15%. So then what laparoscopy followed by IUI. Most of the patient now we understand that surgery is only the second line. Medical management is the first line for pain factor. But in the patient has got infertility with associated pain, then laparoscopy takes course over in that condition. Maybe the laparoscopy in one sitting can give relief to pain for the patient as well as correct anatomically all the abnormalities that are found in the pelvis. That is, you can remove the additions, make the tubes free, you can go for an endometrioma excision, and you can clear the pouch of Douglas, which will help in promoting the normal pelvic anatomy. And immediately following this, so here is the place for endometriosis fertility index, which Dr. Chitra will be talking later. And at the end of the surgery, we have to make a note of this endometriosis fertility index scoring. That is, the score consists of surgical scoring, historical scoring, and ASRM staging scoring and AFS staging scoring, which will be to a total of 10. If the patient's scoring is beyond 6, then her chances of conceiving spontaneously over a period of 2 years is much better. And if the scoring is less than 3 to 4, probably she is a candidate who should be taken for ART soon. So in between 4, 5, and 6 to 7 score, then there are high chances this patient can undergo intrauterine insemination following laparoscopy. And the again success depends upon the age of the patient, ovarian reserve, etc., and the tubal patency. So this is for fertility improvement. Surgical removal of minimal to mild endometriosis increases the chances of pregnancy, but we know the number needed to treat is at least 12. So then IUI following surgery. When should you start doing IUI following surgery? Always you go for surgery, immediately maybe you can give one shot of GnRH agonist, or now we have the oral antagonist, and you should not suppress too much. So then immediately in the next cycle, we can go in for IUI. And again, the protocol is only combining letrozole with gonadotropin cycles, and then you can immediately go for IUI. So it can give roughly the success rate of 10 to 20%. So superovulation is IUI. That is the best option for these patients. And you can expect with the subsequent cumulative cycles, we can expect success rates over 50%. So this is almost parallel with that of the ART result. So then pregnancy rate after COS and IUI for the treatment of endometriosis following surgery is more effective than surgery alone. Suppose if a patient undergoes surgery, then she leaves it without any subsequent treatment, then her chances of fertility falls down again. Then again, any surgery, we know that the chances of recurrence is going to be high. At the end of 2 years, it will be 20%. At the end of 5 years, it can be up to 40%, especially if the patient is not having any post-operative suppressive therapy. So the main thing is we need to go in for immediate fertility treatment following laparoscopy. So after surgical treatment, stage 1 and 2, have to consider IUI ovarian stimulation. And after stage 3 and 4, maybe IVF will be the preferred over IUI, that too based upon the endometriosis fertility index. So all these patients, long-term pituitary downregulation with GnRH agonist prior to IUI might positively influence, but we know that immediately after a good surgery, downregulating with one dose, that is enough for undergoing the patient need to undergo controlled ovarian stimulation and IUI. So this is always preferred. But when we want the patient to undergo ART, maybe now we are all planning for oocyte pickup, embryo freezing, then downregulation, then transfer. This staged procedure is always better. Then role of medical therapy. This is again the hormone. Regarding the hormonal therapy, Yeshre says that it should not be recommended before IUI. Maybe it can be used before IVF in selected cases. So then determining the fertility benefit of controlled ovarian stimulation with IUI after operative laparoscopy in patients with endometriosis, that did not improve the pregnancy rate much in advanced stages, and probably they recommend only IVF. So this is about the endometriosis fertility index, which I have given a details earlier. So the score that is beyond suggests a better fertility outcome, and maybe we can wait for a natural conception or a simple ovulation induction with IUI when the score is beyond 6. But when the score is less than 3, the ideal thing is the patient should go for IVF. Then luteinized unruptured follicles and endometriosis. This is very common. This is because increased pelvic inflammation, altered prostaglandin level, hormonal imbalance. They can interfere with the ovulation mechanics and increase the luteal cycle. And hence, the medication protocols here commonly used are letrozole with gonadotropins instead of clomiphene. Maybe letrozole seems to be a better drug. And adjusting the timing dose based on the previous cycles, we can plan and moving earlier to IVF that can avoid time loss as well as the reduction in the ovarian reserve. Then coming to recurrence. See, people are very, they want to know what is that, how much percentage of them will have recurrence and which patient. So the recurrence, normal recurrence, I have mentioned, this was a study by Sanvi et al. Over a period of 25 years, he has said that 20% by 2 years and 40 to 50% by 5 years. But the recurrence rate in IUI is definitely higher than that of the patients undergoing IVF. This is probably because of the spontaneous rupture when we give the trigger for IUI. So that might slightly increase the recurrence of endometriosis, but this has got only a low quality evidence. So then, can a patient undergoing IUI can have an increased incidence of pelvic inflammatory disease? That is very, very low. Chances are very low if as we are going to do it only in a sterile condition. Approximately maybe 0.16 in 1,000 cycles. It does not increase slightly. It does slightly increase after repeated procedures, but remains rare and no routine antibiotic therapy is needed. IUI and no treatment. When you compare controlled ovarian hyperstimulation with no treatment, definitely IUI has got a better chance of conception. So the cumulative pregnancy rate in stage 1 and 2 are significantly higher than in stage 3 and stage 4. This happens not only for IUI, even in ART cycle, the cumulative pregnancy rates are much higher only in stage 1 and 2 when compared to stage 3 and 4. Moreover, the birth rates are slightly more frequent following IUI procedures than in the group with spontaneous attempts during the 12 months later. So the limitation is there is definitely lower success rate of IUI when compared to ART IVF. No effect, and it is not effective in severe endometriosis, and definitely it needs a fallopian tube. And we know that even in severe endometriosis, stage 3 and 4, still the tubes can be patent, but the chances of hydrosalpinx are quite high, and we must understand that even if they become positive through IUI, the chances of getting an ectopic pregnancy is definitely higher than that of a ART cycle. So the fecundity rate, a meta-analysis of 962 cycles demonstrated that monthly fecundity rate of 13% for stage 1 and 2 and 8% for stage 3 and 4, which is much higher than that reported after a medical and a surgical treatment of the disease. The advantage of IUIs is less invasive, lower cost, simple and quick procedure. Why luteal support is needed in endometriosis? In stimulated cycles, all the patients, they need a luteal phase support. And here again, it is definitely they need in endometriosis patient because inflammation can affect the endometrial receptivity and there can be higher progesterone resistance and the dysregulation of this FOXA and FOXA genes and altered progesterone signaling and inconsistent corpus luteal function. So now the question is when you should move, how long you can do IUI? IUI can be only up to 3 to 6 cycles in patients with young patients with mild and minimal endometriosis. But when the patient is still young and when she is in the stage 3 and stage 4 endometriosis, maybe we can try for 2 to 3 cycles. But in severe endometriosis, whatever be the age of the patient, it is always safer to move to IVF. So in failed previous IUI cycles, you need to go in for IVF. In tubal damage, go for IVF. In recurrence of endometriosis, always IVF is preferred over a repeat surgery. Advanced maternal age as well as in low endometriosis fertility index, it is always safer to move for IVF. So the practical thing is the stage 1 and 2, The recommended approach is IUI with controlled variant stimulation. Stage 3 and 4, it is IVF. Post-surgery, IUI is reasonable in minimal to mild cases. In severe cases, IVF is preferred. Overall, ART IVF gives better results than anything. Than IUI. The key takeaway is IUI works best in early stage. IVF is more effective in advanced stage. Ovarian stimulation is essential with IUI. Limit IUI attempts before escalating the treatment. So the key factors for success is, maybe as I'm repeatedly telling, laparoscopy is indicated only when the patient has got severe pain. Otherwise, ART can be the ideal one when the patient has got multiple factors like endometrioma, tubal factor, and male factor. And always the stimulation factor, protocol should be a combination of gonadotropins with gonadotropins. And that age, optimization of age is very important for the success. Lesser the age, higher the success. And the number of cycles should be limited to 3 to 4. And if the pregnancy is not achieved with that, you have to move on to ERT. In summary, endometriosis patient stimulation with gonadotropin is usually preferred over a natural cycle, as it can compensate for potential follicular development issues associated with the disease. So thank you for the opportunity. Thank you.
Thank you, Dr. Ramni. Your talk was very exhaustive and it covered almost all the points. And I think we get very clear messages when to do the IUIs and how many to limit.
Sanjeev sir, any comment?
No, I just want to, when we understand that there is a disease, especially moderate disease and or severe disease. See, practically, we understand that patient would head for IVF, but then you can't discuss IVF right at the first
Yes.
consultation. And then probably you can buy time by doing 1 or 2 cycles of supervision IUI. If she's lucky, she would conceive. As we said that women with endometriosis conceive even naturally without any doctor's help. Of course, the incidence is much low. But it's not that it is zero. And by the time you are into your second IUI and patient understands that this second IUI has not worked, patient probably would be more eligible for an IVF. That has been my comment. Yes. But I agree with you. Endometriosis, severe stage disease are a problem. And ultimately they head for IVF.
Shini, shall we move on to the third presentation?
Pallavi, can you
Share
show?
Yeah, Priyanka.
Yeah, very good afternoon, ma'am, and good afternoon to our esteemed faculty.
So Dr. Priyanka Dilip Kumar, she has done her MBBS, DNB, FRM, FICOG. She's a consultant reproductive medicine, Land Fertility and Birthing Hospital, Bangalore. She's consultant OBGYN, Anugraha Nursing Home, Bangalore. She's member of Bangalore Society OG, FOXY, ISAR. Presented papers at state and national conferences. She was faculty at various national conferences, UVA, FOXY, AICOG. She's involved in teaching fellowship students at Milan since 5 years. And she has her publications are she's co-author for chapter on tuberculosis in pregnancy and textbook on congenital intrauterine infections in 2009, co-author for chapter on PPH in AICOG update 2016 January, co-author for chapter in labor room emergencies, author for prevention of OHSS FOXY Focus 2024, co-editor for book on obstetric hemorrhage, evidence-based practice and recent advances, author chapter Impact of Obesity on Reproductive Health in ICOG campus on obesity, Jan 2026. We welcome you, ma'am.
Thank you so much. Thank you, Ramani ma'am, for this opportunity. Can I share my screen? Is it visible now?
Ma'am, only you are visible. I'm not able to see your screen.
Now? No?
No, Pallavi, you have stopped your screen sharing, right?
Yes, I have stopped the screenshot.
Now?
Yeah,
No,
now we are able to see.
now, yes.
Yes.
Yes,
Thank you.
yes, that's fine.
Yeah. So the topic given to me is ART and endometriosis. It is a very vast topic, and I think the former speakers have elaborated very well, and some of those points also are there in this presentation. Endometriosis can be encountered in approximately 30% of infertile women. Various mechanisms can cause infertility here. In this topic, we are going to see how ART fits into fertility care, when it helps, and where clinical judgment matters. So, we are looking at infertility pathways, IVF, ICSI, ovarian reserve testing, and a patient centered strategy. So, I have organized this talk into a brief review on pathophysiology. Where does ART come in? How to choose between expectant care, IUI, IVF, and ICSI? What is the impact of surgery and endometrioma on ovarian reserve? IVF protocols and practice algorithm and counseling points. So, endometriosis affects fertility by various mechanisms. It could be inflammation, it could distorted tubo-ovarian anatomy, adhesions, endometriomas, symptoms, age, ovarian reserve, stage of disease, and prior treatment all shape the fertility plan. Because mechanism is mixed, treatment needs to be individualized than stage-based. So, as I mentioned, it is the anatomy which gets distorted. Ovarian reserve with endometrioma may reduce by reducing follicular pool and response to stimulation. Peritoneal inflammation impairs oocyte quality, fertilization, and implantation environment, and the burden of pain causes dyspareunia. Chronic pelvic pain reduces quality of life and conception opportunities. So, ART is the cornerstone in managing infertility linked to endometriosis. So, there is enough evidence to show that IVF and related outcomes IVF yields to outcomes comparable to women without the condition when tubal dysfunction is absent. But this infertility problem is not the same in every patient. A young woman with minimal disease with endometriosis and a normal reserve is very different from a woman who's 36 with bilateral endometriomas. Stage alone cannot predict fertility potential or dictate treatment. So, age, duration of infertility, or ovarian reserve, tubal status, male factor all matter. So, ART must be used selectively and strategically, not automatically. See, ART is not the first for everyone, especially IVF, but it is a central for many. As mentioned in the previous talk, mild disease, expectant management, ovulation induction, IUI is fine if age and reserve are favorable. But as it progresses, moderate to severe disease, IVF is better because it bypasses the distorted anatomy. Older women, ART is prioritized early to avoid losing time when ovarian reserve is already declining. And after failed surgery or IUI, it is better to escalate to IVF. When ART enters the treatment pathway, first step, evaluate the patient. Second step, see if she has the lower complexity options. Try IUI, but escalate. When time is limited, anatomy is distorted, IUIs have failed, or reserve is at risk. Expectant management and IUI may still be reasonable. Minimal mild disease with patent tubes, younger women. But also for some patients, as we said, who do not want to go for an IVF directly, maybe 1 or 2 cycles. But prolonged delay here is unhelpful. So treatment should remain time conscious. Treatment choices often not only depend only on endometriosis stage, but the patient's age reserve and prior history also. So, to summarize, why IVF in endometriosis? Because there are adhesions, tubal blockage, distorted anatomy, patient suffers from chronic pelvic pain, dyspareunia, the inflammatory response damages oocytes, sperms, and fertilization, poor ovarian reserve, and advanced stage. How to choose the right treatment pathway here? Which ART approach matters the most? As mentioned before, IUI for selected patients, minimal or mild disease, and patent tubes. IVF is the main strategy. It bypasses the tubal dysfunction and minimizes delays. and ICSI is added when there is male factor or patient has had prior fertilization failure, or maybe when the lab there's a strategy to favor controlled insemination. So, do all cases of endometriosis require ICSI? Not necessary. So, IVF is sufficient when the semen parameters are normal, but ICSI is chosen for male factor infertility, previous poor fertilization. But nowadays, because male factor infertility, we do see more and more cases. Most of the labs have moved from IVF to ICSI. Common scenarios that can change the plan. Now we have planned IVF, but things that can change this plan is endometrioma. This often complicates retrieval access, infection, and reserve preserving surgical decision must be taken. Deep disease is associated with severe pain, but IVF still can be effective. Recurrent surgery, recurrent disease, repeated surgery is not preferred here. It lowers ovarian response, shifting the balance towards early IVF. And adenomyosis can often overlap. This can influence implantation strategy, pre-treatment choices, and embryo transfer planning. So, coming to GnRH pre-treatment strategies before IVF or ICSI that's used to suppress disease activity and improve ovarian response and implantation. Evidence has shown some benefit in clinical pregnancy rates, but live birth improvement is uncertain. So, we have GnRH agonist pre-treatment. They act by reducing, by causing pituitary suppression, may improve implantation rate, but severe endometriosis cases only. Progestin, like we can use Dynogest, anti-inflammatory, but no significant benefit in the outcomes. Aromatase inhibitors sometimes are prescribed because they reduce local estrogen synthesis, promising, but again, evidence is lacking. Surgery for deep infiltrating endometriosis, lesion removal possible, but we have to evaluate this case and case by case. So the key insights here are endometriosis reduces ovarian reserve and oocyte quality. So there are fewer embryos. Advanced stages are detrimental when endometriomas are present. Novel therapies like allogolics and PPOS protocols have shown to improve oocyte yield. Age and AMH levels are independent predictors, and adjunctive strategies may optimize outcomes but require individualized planning. So the protocols, key protocols, GnRH agonist and GnRH antagonist protocol. GnRH agonist protocol has advantages. Higher number of oocytes are retrieved, may improve cumulative pregnancy rates. Disadvantages, there's longer stimulation, higher gonadotrophin required, and more costly and more burdensome for patients. GnRH antagonist protocol, shorter duration, lower gonadotrophin use, but maybe fewer oocytes retrieved. Outcomes wise, generally, according to studies, the clinical pregnancy and live birth rates are comparable. So, this is long agonist protocol. Previous cycle, day 21, GnRH agonist is given. We can give leuprolide, triptorelin, buserelin, or we can give depot preparation of 3.75 milligrams. And then once the patient gets the period, gonadotrophins are started. That is, the dose is adjusted according to her age, AMH, BMI, and then HCG trigger is given. The dose of the agonist is halved once the patient gets the menses and starts gonadotrophin. Next is the antagonist protocol. GnRH antagonist, usually it is given as multiple doses only when the lead follicle is 12 to 14 mm or E2 is 300 to 400. Comparison of both, as we already said, the agonist protocol has down regulation of pituitary, so it takes longer to act. Recovery time is 2 to 6 weeks. More gonadotrophins are consumed, and trigger is HCG only. GnRH antagonist has advantage. Recovery time is immediate, and we can also give agonist trigger to the patients. So prevention of OHSS is better. The other protocol which we commonly use for endometriosis patients is called as the PPOS protocol, where we do not, instead of the injectables, we give tablet meprate from the time the gonadotrophin is administered up till the trigger, 10 milligrams per day, OD dose. So we compare both. We have various protocols, long GnRH agonist, GnRH antagonist, mild IVF, usually not preferred in endometriosis. and surgical pre-treatment for the removal of large endometriomas, and hormonal pre-treatment, aromatase inhibitors or progestins to reduce inflammation. So, coming back to this comparison between the two, GnRH antagonist better at preventing OHSs, less gonadotrophin use, but less number of oocytes may be retrieved. Long GnRH agonist protocol, longer treatment, more gonadotrophin use, but may have a better oocyte yield. So, now coming to frozen embryo transfer in endometriosis. What are the key concepts here? Endometrial preparation. So we usually follow the HRT protocol where endometrium is primed with exogenous estrogen followed by progesterone. This has good cycle control and flexibility unlike natural cycles, so it can help clinicians to schedule embryo transfer with precision. Sometimes we do give down-regulated HRT, so GnRH agonist is given in the previous cycle around the day 21. Advantage is predictability, easier scheduling, and better outcome. Disadvantage is that there is daily medication, higher risk of thromboembolic events, and may slightly increase obstetric complications according to some studies. So, HRT cycle is most preferred in endometriosis patients as compared to natural cycle or modified natural cycle or stimulated cycles. What are the risks here? Endometriosis flare up can occur, prolonged estrogen exposure. Pregnancy outcomes, better pregnancy rates may be there, but there are certain higher risk of hypertensive disorders and preterm births in HRT cycles. So, what are the challenges with IVF in endometriosis? There is already reduced ovarian reserve because endometriosis itself can damage ovarian tissue, lowering the egg count and quality. Endometriomas large, more than 3 centimeter, may require removal before IVF. The inflammation and adhesions can impair implantation and embryo development. Lower success rate, less number of embryos also means need for pooling cycles. The patients need more cycles compared to women without endometriosis. So, if we compare endometriosis patients with non-endometriosis patients and IVF outcome, endometriosis patients with endometriomas, advanced stage, lower AMH will have a less oocyte yield. Embryo euploidy rates may be similar. Implantation rates and frozen embryo transfer is comparable. Live birth rate may be comparable, may be slightly lower in advanced cases. And benefit of surgery, possible improvement is there in patients with endometriosis with stage 3 and 4 disease. So, to summarize, IVF in endometriosis, steps to improve success, pre-treatment planning, hormonal therapy or surgery, tailored stimulation protocols, safe egg retrieval, especially when the endometriomas are already present, careful embryo selection transfer, embryo freezing and subsequent frozen embryo transfer. So, surgery versus IVF, often a dilemma for an ART clinician. The hard question is often not whether surgery helps, but when it helps. Protecting ovarian reserve is as important as treating lesions. Severe pain, suspicious masses, hydrosalpinx, inaccessible follicles, or distorted anatomy, preventing safe retrieval may push for surgery. So, what are the factors favoring surgery? A younger woman, no previous surgical history, when we difficult to rule out cancer, has severe pain, and ovarian follicles are inaccessible, go for surgery. But in an older woman, no previous history of surgery, no suspicious features suggesting ovarian cancer, recurrent endometrioma, and has associated infertility factors like male factor, low ovarian reserve, go directly for IVF. Surgery before IVF can help symptoms, but it can also cause the follicles. Large or painful endometriomas justify surgery for symptoms, for access, for suspicion of atypia or infection concerns. But cystectomy also removes healthy ovarian tissue and lowers reserve, especially after repeat procedures. For asymptomatic cysts before IVF, surgical teams may avoid routine surgery unless retrieval access is compromised. So the decision is always must weigh on pain, anatomy, prior surgery, AMH, antral follicle count, and age. So should endometrioma always be removed before IVF? No. Routine removal of an asymptomatic endometrioma before IVF is usually not advised unless it is in the way of ovary. Surgery may be considered. Again, as mentioned, pain is a very important factor and difficult access to the follicles. Decision, of course, has to be taken based on the size of the endometrioma, whether it is bilateral. Has she had a surgery before? Goal is we have to protect the fertility potential and also make sure that it is safe for the patient. So, what can't ART overcome? ART has strength. It can bypass tubal distortion and accelerate conception, but it cannot fully erase the effect of inflammation, reduced reserve, diminished oocyte yield, or repeated surgery. Success varies by age, embryo quality, stage of disease, reserve markers, lab quality, and associated infertility factor. ART improves route to pregnancy in endometriosis, but prognosis largely depends upon the baseline biology and prior treatment history. So, how to tailor ART regimens in endometriosis? Check her ovarian reserve, talk to the patient about the egg yield, and also ask for counsel for early IVF. Stimulation protocols should balance response, prior cycle history, and risk of poor ovarian response or decreased ovarian response must be kept in mind. Fertility preservation may be considered before repeat surgery. Pain control, surgical history, and access to ovaries often influence the retrieval planning. Counseling is strong when fertility goals and symptom goals are discussed together, not separately. So, the double edged role of surgery before ART benefits are that it reduces pain, improves anatomy, can remove a suspicious mass, and improve accessibility to follicles, but can lower the AMH, reduce AFC, and make future IVF response poor. The outcomes is we can expect that many patients will achieve pregnancy through ART. Limitation is the response to stimulation and number of oocytes. Age is a very important predictor of success, and the clinical message is that, oh, again, ART can overcome the anatomy and the delay, but the ovarian aging is something which it cannot reverse. Timing matters so much. Every additional surgery or prolonged trial of low success treatment can cost valuable time. In patients with low AMH or advancing age, early IVF is rational. Some patients may also benefit from freezing of embryo freezing or fertility preservation. So what should patients understand? ART is a fertility treatment, not a cure. Symptoms can persist even if fertility is addressed. Treatment selection depends upon the balancing of pain and her fertility. Prior surgeries, age, and AMH influence the decision making. So, first step in a clinic, assess the couple, especially the woman. Step two, if she has mild disease, consider IUI. If prognosis is poor, age is more, reserve is reduced, move to IVF. Avoid routine pre-IVF cystectomies. So the ASHRAE guidelines, to summarize, said individualized management. IVF is recommended for women with endometriosis related infertility when other treatments will fail. Routine surgery is not advised unless there are very large endometriomas with severe pain. Medical therapy, hormonal suppression does not improve pregnancy rates. Not encouraged here. Ovarian reserve. Surgery may reduce ovarian reserve. Consideration must be given. Fertility preservation should be considered in a woman at risk of low ovarian reserve. ASRM committee guidelines say IVF, according to effectiveness, IVF bypasses pelvic adhesions and distorted anatomy, making it effective for moderate to severe disease. Surgical treatment can improve fertility. Medical therapy, suppressive medical therapy, GnRH agonists, does not improve fertility outcomes and can delay effective treatment. Removal of endometrioma may be considered if cysts interfere with oocyte retrieval. So, to compare both the guidelines, ASHRAE does not routinely recommend surgery. ASRM says it may help in stage 3-4 disease. Both do not recommend medical suppression. Endometriomas avoid routine removal according to ASHRAE. IVF, both the guidelines say that yes, it is effective. And emphasis here in ASHRAE is on personalized care. Cautious about ovarian reserve. And ASRM says surgery may help the anatomy. Medical therapy is discouraged. According to the Cochrane reviews, there were 4 randomized control trials included. One was GnRH agonist versus antagonist protocols. Agonists improved ovarian response and number of oocytes, but did not significantly improve clinical pregnancy rates. Surgical aspiration versus expectant management. Aspiration showed better ovarian response, but evidence was limited. No trial reported on live birth outcomes, which was a major limitation here. Systematic meta-analysis in 2026 said that women with endometriosis undergoing ART had lower clinical pregnancy rates and lower live birth rate compared to controls, with higher risk of obstetric complications were observed, like PPH, placenta previa, preterm birth, cesarean section, low birth weight. And a large registry study in 2017 showed more than 22,000 cases. Women with endometriosis had fewer oocytes retrieved with no significant difference in live birth, clinical pregnancy, or miscarriage rate. So, ART in endometriosis is rarely a one size fits all. Treat the patient, not just the lesions. Earlier referral to IVF is better, and the decision should be to protect ovarian reserve and pain and fertility both matter. In endometriosis, ART works best when it is used neither too early nor too late, but exactly when time, anatomy, and ovarian reserve make it the smartest path to pregnancy. ART is a major fertility tool in endometriosis. It bypasses anatomy, saves time, and can be individualized around ovarian reserve and symptom history. So, to summarize, endometriosis causes infertility through inflammatory, anatomical, and ovarian mechanisms. ART is valuable, it saves time. IVF is the main ART tool. ICSI is reserved for male factor. Routine surgery is not always beneficial, reduces ovarian reserve. Management must be individualized. Thank you.
Sudha madam, you can give your comments. Priyanka, you can stop sharing your presentation.
Yes, ma'am. Yes, ma'am.
Sudha madam, you can give your comments, madam. I don't know why. Priyanka, otherwise it was a very nice presentation. You have clearly indicated when the patient should be shifted for ART and the need for pre-operation, surgical indication for planning in patients planning for ART. And you have discussed what will be the individualization of the protocols. And I think that at the end, I personally feel if you do a proper IVF, segmented IVF, the results are the same because the recent, all the guidelines, everybody say, though the quality of the eggs and the number of oocytes retrieved are less, proper segmented IVF with the proper protocols will definitely give us the equal proportion of outcome, better outcomes compared to male and other keyboard factor. So the key take-home message is
individualized
individualization, and don't wait for a long time. Better to go in for early ART in endometriosis. And especially if they have multiple factors, I think even suppose if the patient has got an associated tubal like a hydrosalpinx or a suboptimal male factor, early ART is indicated.
Madam,
Sanjeev sir,
yes. No, I just wanted to ask you, what are the miscarriage rates in an IVF, and is it different in endometriosis? In IVF, that's right. What has been your experience?
Priyanka?
How many miscarry?
Ma'am, in terms of overall miscarriage rate, I think age is more a factor rather than endometriosis alone. At least in my experience, age plays a better role. But having said that, I feel still IVF patients are at increased risk of miscarriage as compared to patients who conceive spontaneously or through IUI. because
Yes.
more than 50% of the patients have bleeding or spotting in pregnancy, IVF patients, and at least about 25% of them might end up losing the pregnancy.
And adenomyosis is one of the important.
Associated adenomyosis increases the
Adenomyosis.
incidence of miscarriage rate, as well as the implantation rate is halved when the
Yes,
patient,
yes.
patient, the same comparing a patient with only isolated endometriosis and endometriosis with adeno, your results are definitely halved in patients with adeno.
Yes,
So that-
ma'am. And many of them do have associated adenomyosis.
Yes, 30 to 70% varies.
What is the miscarriage rate in women who don't have endometriosis and conceive with IVF?
That depends upon the age.
No,
and
no, but no,
everything.
no. Let's if
Yeah,
you
they
In
may get
endometriosis,
to
I think it
15%.
would be 10 to 20%.
How much
One
is
in
it?
five,
But
one in five
patients,
would
they
have.
is high.
How much is it?
1 in 5, but 20%, but it would increase with the maternal age.
Okay, so average 20% will miscarry.
20 to 25%.
Okay, and in endometriosis it would be a little more maybe.
Yes.
Okay, so maybe 25.
Yes.
Okay. See, the
But
various
we
types
know
of
practically we feel that endo patients, they have a high risk of
high
miscarriage.
risk. I agree.
That is obvious.
And, yes, and they miscarry probably before the fetal heart, I suppose.
Yes.
Yes.
Maybe because associated environment, there is inflammation. So
But once you have the fetal heart, then probably the chance of miscarriage would be less.
Yes.
less. Yes.
That's for
So
any-
down-regulated HRT protocols work well for FET, for endometriosis.
Okay.
Actually, three areas I just want to highlight. Number one, regarding IUI, the semen preparation. The semen preparation is of prime importance, and it varies from lab to lab or center to center. Number two, IVF center. A lot of IVF centers are doing everywhere. Now, it is very important to know where this all protocols are being maintained and which is the standard and well known for the others. And regarding the last part, adenomyosis, all these things have been that has been discussed already. Regarding uh, abortion, we have not uh, gathered the data so far. Pre-implantation miscarriages are concerned. This one area is not being taken into account. So you need to think of these areas in the future. So, but endometriosis and adenomyosis are discussed.
Okay, Arshini, shall we move on to the fourth speaker, Dr. Chitra?
Pallavi, can you share your screen for Chitra ma'am's CV?
Priyanka, thank you so much. Yeah.
Thank you.
Ma'am,
I'm
thank
very
you to all
happy
the
to-
faculty.
Thank you.
So I would love to introduce Dr. S. Chitra ma'am, MD, DGO, FICOG. She's founder and director of Journey Fertility Center, Pattukotai. She's founder and director of Lalita Nursing Home, director of Shamla Nursing Home. She's underwent IVF training at Singapore under Dr. P.C. Wong, underwent IVF training under B.N. Chakravarti, completed undergraduation from Tanjore Medical College, post-graduation from Manipal University, and won the Best Outgoing Student Award. She's passionate on infertility and started the first IVF center in Trichy in 2004. She's invited speaker and faculty in many national conferences. She's secretary of IFS South Tamil Nadu chapter, organizing secretary of International Conference Endometcon, past president of TRIOX, patron of TNFOG, assistant secretary TNFOG, organized many public awareness program in schools and college. Ma'am, we welcome you.
Thank you. Thank you, Harshini, for that introduction. Let me share the slides now. Thank you, Ramni, for the opportunity. I hope am I, can you see
Yes,
my
ma'am,
slides?
yes, ma'am, we are able to see.
Make it full screen.
Yeah, I'm making it. Thank you.
Yes.
Thank you for the opportunity. And I'm here to talk about the role of endometriosis fertility index in planning treatment for infertility. We all know endometriosis is associated in infertility as high as 30 to 50% of women who come to you with infertility. And there are different classification systems that are available to classify endometriosis. And the most popular is the revised ASRM or the American Fertility Society classification system. And predicting fertility after surgery is a big challenge. And because surgery does not really match with the outcome for infertility. Endometriosis fertility index helps us to estimate the natural conception rate after operative laparoscopy. So we all know 7 to 10% of women are affected by endometriosis and 30 to 50% of this population experiences infertility. And the main mechanism is because of the inflammation. Cytokines and oxidative stress alters the peritoneal fluid, creating a hostile environment for the oocytes and the embryos. That's how infertility comes in. And the anatomical distortion causes fibrotic adhesions are caused by the fibrotic adhesions. Tubal blockages do occur. Ovarian endometriosis reduces the overall ovarian reserves, and all these put together produces infertility in these women. And the saddest part is the anatomical severity does not equal to really functional outcome, because we are talking about fertility outcome in infertility and it does not really match, because the most severe person sometimes they become pregnant on her own, and the one who has a small endometriotic cyst doesn't turn pregnant at all in spite of many treatments available to them. So the different classification system, see it all these things focus on the disease itself. It has been since 1996. There's been this revised ASRM, and in 2011 it is the enzyme, and then again the AAGL in 2021, and we have the AFI or the endometriosis fertility index, which was designed in 2010. In spite of all these things deal with the anatomical burden, but the enzyme classification talks more about the deep infiltrating lesions, and it does not tell you anything about the predictive value of their pregnancy. And it has very, very complex, and it's very difficult for us to understand and then make the patients understand what it is and where they are. And again, the AIGL, surgical complexity and pain is there always, and it only gives you a very limited approach towards the fertility prediction, and it requires again intraoperative data. Of course, EFI also involves operative data, but it does not attend any or give any attention to the pain or the pelvic pain that is related to endometriosis. And fertility prediction seems to be very, very good in endometriosis fertility index. So this actually comprises of 10-point score. It involves the age, the historical factors and the surgical factors. About 50% comes to the history of the patient, and the rest of the 50 is related to the surgical factors. You have to take into consideration the age of the patient and the number of years the patient has been infertile, and the history whether she has been previously pregnant or not. Then coming to the surgical factors, you have to take into account the least functional score, the revised ASRM lesion score, and then the total ASRM score. This was designed by Adam and Pasta in 2010. And when it comes to history, there are points given to all the age groups. So when they are less than 35, it is about 2 points. If it is 36 to 39, it's 1 point. And it's 40 years and above, it's given 0. And years of infertility, again, when it is greater than 3 years, the point is 0. And when it's less than 3, it is about 2. Similarly, if they have already had a pregnancy before this, then they have 1 point. And if there are no pregnancy, it has been 0. So when it comes to least functional score, we have to know about the function of the tube, ovary and the fimbria. All these things have to be correct for fertility to really be good. So because of that, you have to assess where the mistake is and you have to score them accordingly. If there is complete obstruction in the tube, it's going to be 0. If there is mild dysfunction of the fimbria, it's going to be 3. And if ovary and tubes are functioning good, it's going to be normal. So again, you have this entire system. That was just a pictorial, visualization for us to know what is what. And here is how you would really sit and calculate. So tube, if it is mild, if it is moderate, severe, non-functional, you give points according to it and then total it up on the left and the right and make the total function score or the least function score, which will be around 8 if you calculate both together. And this is the revised ASRM score or the American Fertility Score. This is very cumbersome for all of us to understand because we have to know where the lesion is, whether it's at the peritoneum, it's at deep or it's superficial, it's at the ovary, whether the cul-de-sac has been totally covered with adhesions and all that. So after each surgery, we'll have to sit and elaborately mark all these things and identify whether the disease in stage 1, 2, 3 or 4. So if it is going to be normal, it's going to be good. There you will have no lesions or anything. If it is going to be 5, if it's going to be mild, it's going to be anywhere between 0 and 5. If it is going to be moderate, it's going to be between 5 and 15. And anything beyond 16 is not going to be good. And beyond 40 is going to be really bad. So this is how we classify and keep all these points together and put everything together to collectively know what is in endometriosis fertility score. So here again is a visual calculator for endometriosis fertility index. So with all these things, you have a maximum of 10 scored by endometriosis fertility index. This is what is available as a table on the net. So we can download this, put it onto the case sheet as soon as we do an endometriosis surgery, and then do all the ASRM staging, then put those points and the least functional score points together and know their history, put everything together and mark it on the graph below for us to talk to the patients better. So this is how the EFI scoring system works. The higher score indicates better fertility. So if the score is anywhere between 0 and 3, it's good. They are going to have a very poor prognosis related to infertility. When the score is between 4 and 6, they have intermediate prognosis. And when it's beyond 7, they are going to have a good prognosis. So it's usually calculated after the surgery. So it helps to counsel couples regarding fertility potential, guides us to make a good decision between expectant management and assisted reproduction, and helps us to delay time line to wait for IVF. So you can push them earlier for an IVF if necessary. So EFI and natural conception has been good when the scores has been high. So EFI more than 7 is associated with favorable natural conception rates. There are enough data available on the net which says that if the score is between 0 and 3, the pregnancy rate after 1 and 3 years has been only as low as 10. Whereas if it is between 7 and 8, it has been as high as 39 after 1 year. And it has been even 66% if you wait for 3 years. And it has been up to 75% if you wait for 3 years in someone who has a score of between 9 and 10. This has been documented even in the year 2010, and again it has been updated in the year 2020. So we can put this down in our table and then it will be easy for us to counsel all those infertile people who have had surgery for endometriosis and tell them what would be their chance of conception on their own, what will be the chance of conception when they go for IUI, and next for IVF. So to supplement my data, what I presented so far, this is the review of literature. So endometriosis fertility index for predicting pregnancy after endometriosis surgery, they have very clearly mentioned that the least functional score is the most influential factor. So if the EFI in this study, they have said if the EFI has been more than or equal to 5 after 12 months of surgery, they have had better pregnancy rates with ART than waiting for an expectant pregnancy or a natural pregnancy. Okay, so endometriosis fertility index for prediction of non-assisted reproductive technology, pregnancy after endometriotic surgery. This is a systemic review analysis, a meta-analysis of 17 studies with 4,598 women were taken into consideration. Here again, it shows the same data. So when it has been 0 to 2, it has been 10%. When it is between 9 and 10, it has been as high as 69%. So we should know when to stop waiting for a natural conception and when we have to push them for ART at the earliest. So infertility management according to endometriosis fertility index in patients operated for endometriosis. What is the optimum time frame? How long can you wait? So here again in this study, there have been 234 patients. Out of them, 104 has conceived after surgery and 58 had spontaneous, 108 conceived after surgery, 58 were spontaneous and 34 with 0 to 4 EFI and 52 with EFI more than 5 to 10. With ART, 12 of them conceived And again, it was correlated with the endometriosis fertility index. So they have found that fecundability decreased after 12 months and 24 months in 0 to 4 groups and 5 to 10 groups respectively. So conclusion, we should understand that if it is an unfavorable EFI of less than or equal to 4, it should be referred to ART as early as possible after surgery. And if it is a favorable EFI more than 5 or equal to 5, you may probably wait for spontaneous pregnancy or go for an IUI, but not wait beyond 24 months even in those patients. So EFI and assisted reproductive technology again says low EFI score may indicate earlier need for IVF. Improved individualized fertility planning should be planned for them. You can probably tell them that ineffective repeated surgeries may be ineffective, and you have to educate them what their disease is and tell them to make a quicker decision on ART. So advantages of AFI is it's a very simple thing to calculate. It is clinically very practical. It is validated in multiple studies. It's a better predictor than revised ASRM score because that does not deal only with surgery. It also incorporates history into it. Cost-effective fertility counseling tool and helps us to formulate personalized treatment. So only thing is, again, this also requires a surgical assessment. It does not directly predict IVF success, but it tells you about the fertility potential. So inter-observal variability may be there, but it is not very bad to be incorporated. Less useful in severe male factor. That's one thing which it does not address to at all. EFI is endorsed in several reproductive medicine practices, several studies that are related to it. Study shows strong correlation between EFI and the pregnancy outcome, frequently cited in ESHRA as well as ASRM in fertility literatures. So to conclude, I would say EFI, when it is beyond 4, 5, you have definitely a good pregnancy rate. See, it increases about 50%. But if it is below 5, you have to keep your fingers crossed because it's going to be less than 50%. Again, waiting too long. If you have to decide quickly on assisted reproduction at the earliest. If it is going to be less than 4, higher cumulative pregnancy rates are there when you use surgery plus ART, then wait for natural conception. So to sum up, laparoscopic surgery will help us to calculate the ASRM score as well as the least functional score. Then you put everything history together and calculate the fertility index. If it is 0 to 4, it is unfavorable. So attempting natural conception for less than 12 months, then prompt escalation to IVF would be better. If it is between 5 and 10, it has a favorable prognosis. So you can attempt natural conception or IUI for 12 to 24 months. Then even after 24 months, it's always better that we tell them you would have better pregnancy rates with ART. So EFI shifts clinical focus from solely managing the anatomical disease and just thinking that surgery would help these patients to become pregnant. You have to tell them what is the real scenario and make them become successful parents. Thank you very much for the opportunity. Again, this is a conclusion that would say EFI is an important prognostic tool in endometriosis associated infertility. It helps us to personalize fertility management after surgery. Higher EFI score correlates with better spontaneous conception rates. Support is definitely evidence-based, and counseling can help us in planning the treatment. Thank you.
Thank you, ma'am, for the very knowledgeable presentation. To Ramani, ma'am, for your inputs.
Sudha madam, you want to give your comments?
So in a very nice talk, very simple way of assessing, and we can get updated. Our practices can be updated just after post-surgery, how long to wait and where to direct. So it is a individual tailorized treatment for this EFI. And I think we should all incorporate it in our practices. And very nicely and very legibly and clearly spoken by Dr. Chitra. She has done a nice job about it.
Thank you, madam.
I think every patient who undergoes surgery for endometriosis should be given at the back the endometriosis fertility index. So that will guide when she goes for an infertility consultant, it will guide what should be the plan of management. Sanjeev sir, for you, from you?
No, I fully endorse and agree with you because it's a very handy tool, simple, I would say, though subjective, but then it gives you a way forward, you know, and especially the patient is a part of that whole decision-making program. I agree with you.
So, thank you, Dr. Chitra, for your very crystal clear, simple presentation.
Thank you.
Sir, then Pradeep sir, do you want to have any comments? Or shall we move on to the quiz? That is MCQs. Harshini, I think you can go ahead with the MCQ questions. What about Priyanka? You want anything to add up? Unmute, Priyanka, unmute.
Yes, ma'am. The AFI system is very good, ma'am, as compared to the other classification systems because they are more focused upon the deep infiltrating endometriosis and surgery, whereas this will provide a better prognosis and, about the fertility outcomes and
Now
success.
they have come out with another EFI, modified EFI score where they don't do the surgery at all. The tubal
They do
patency,
it.
everything is being
Yes.
done by the ICOG or HSC. And just a simple imaging system is helping so that we can avoid triage laparoscopy itself. And if you expect a lesser score, then straight away the patient can be shifted to ART. That is the advancement in the EFI scoring now.
And also, ma'am, about the AMH and the male factor, which is not included.
The limitation is male factor is not included and AMH is not included. See, for example, if a patient with a good EFI score of 7 or 8, if her AMH is low or if the male factor is abnormal, then again she has to be shifted to, we need not wait for 2 years for the natural conception. So probably this is the limitation of endometriosis fertility index.
Though it is not included in that, probably we will take that history when we are doing the history. It's not mentioned there in that history part of it. Probably next time they will improve that also.
We have to improve
So when you
that.
do the history itself, you will know for what these patients are landing with you for infertility. So at that time, you will probably rule out those reasons. So that's why they have not given a big weightage for those 2 points.
Yes, ma'am.
Maybe in the history, we can add up these 2
That's what.
points.
That's what, because this is related to the disease, they have put importance only to that. And they have excluded these 2 points which are not directly related to the disease.
Fertility.
Sudha madam, can we move on to the MCQs? Actually, start posting.
Thank you.
Late.
Jignesh, please set up the quiz.
Okay, ma'am. Just give me a minute. Hello, viewers. You can see this is a live going on. Exit from the full screen if you are doing, and you can see here is the our MCQs will be come.
Ma'am, I'll start.
Just a minute.
Yep.
Jignesh, it is not seen in the screen.
Yeah. Just give me 1 minute, ma'am.
No, it is not seen. It came, it just went off.
Okay. Yes, ma'am. You can start.
Yeah.
Natural pregnancy rate per cycle in endometriosis is A, 15 to 20%, B, 10 to 15%, C, 5 to 10%, D, less than 5%. The answer is D, less than 5%.
You wait for some time.
The time is running actually. Endometriosis affects successful ovulation by A, altered or defective folliculogenesis, B, LUF, luteinized unruptured follicle, C, progesterone resistance, D, all of the above.
All of the above?
Ma'am, there's 10 more seconds left. 7
All of
seconds.
Yes. Now the answer is
The answer is
above.
D, all of the above.
Next question.
Tubal involvement in endometriosis and PID. Tubal involvement is both endometriosis and PID. Tubes are more affected in endometriosis. C, tubes are more affected severely in PID.
Both?
Yes, you have 9 more seconds.
Is it A?
No, the answer
A.
is C. In PID, the tubes are more affected.
Yes, because invariably the tubes are patent in endometriosis.
Endometriosis causes infertility by affecting A, oocyte, B, sperm, C, fertilization, D, implantation, E, all of the above.
All of the above.
Yes. So the answer is E, all of the above. Endometriosis affects sperm by causing sperm DNA damage, B, reduced sperm motility, C, impaired acrosomal reactivity leading to diminished penetration, D, all of the above.
All of the above.
All of the above?
Yes.
Allow the other people to answer. So because they have to record it. Okay.
The answer is all of the above, D.
Then go ahead.
6. Which of the following mechanisms best explain reduced ART success rates in women with endometriosis? A, altered folliculogenesis due to impaired vascularization. B, decreased ovarian reserve. C, reduced endometrial receptivity. D, increased inflammatory cytokine activity. And you have 10 seconds left. A, altered folliculogenesis due to impaired vascularization. In women with endometriosis undergoing IVF, which intervention has shown the most consistent improvement in pregnancy outcomes? A, routine laparoscopic excision of minimal lesions before IVF, long-term GnRH agonist pre-treatment prior to ART cycles, immediate IVF without surgical or medical pre-treatment, ovarian stimulation with clomiphene citrate alone.
Is it C?
5 seconds
Is
left.
it B? Long-term agonist.
Wait. Don't answer.
B, it's long-term. Ma'am, the students are actually answering, ma'am. We are in the speaker's link, but the students are answering.
Okay.
Which statement regarding the oocyte quality in endometriosis patient is most accurate? Oocytes from endometriosis patients consistently show high fertilization rate. Endometriosis primarily affects oocyte competence through oxidative stress and altered mitochondrial function. C, oocyte quality is unaffected by the presence of endometriomas. Endometriosis improves embryo cleavage rates. B, endometriosis primarily affects oocyte competence through oxidative stress and altered mitochondrial function. 9th, what is the current consensus on surgical removal of endometrioma before ART? Always recommended regardless of cyst size, never recommended due to the risk of ovarian reserve loss. C, considered when cysts are greater than 3 to 4 centimeters, symptomatic or hindering the follicular axis. D, mandatory for all patients prior to IVF. C, considered when cysts are greater than 3 to 4 centimeters, symptomatic or hindering the follicular axis. 10. Which ART outcome parameter is most consistent produced in women with moderate to severe endometriosis compared to controls? A. Fertilization rate. B. Implantation rate. C. Embryo cleavage rate. D. Blastocyst formation rate.
Implantation rate.
It's B. Implantation rate. What is the maximum EFI score? A. 5. B. 8. C. 10. D. 12. We have 10 seconds left. C10. EFI is mainly used to predict A. IVF complications, B. Natural conception after surgery, C. menstrual regularity, D. ovarian cancer risk. The answer is B. Natural conception after surgery.
Or
13th, which is not included in EFI scoring? A. Age, B. Blood group, C. Prior pregnancy, D. Duration of infertility. The answer is B. Blood group. A higher EFI score indicates better fertility prognosis, need for hysterectomy, C. Severe disease only, D. Poor ovarian reserve. The answer is A. Better fertility prognosis. EFI was developed by A. Figo, B. Adamson and Pasteur, C. WHO, D. ACOG. The answer is B. Adamson and Pasteur. Which statement regarding IUI in endometriosis is true? A. IUI is contraindicated in all stages of endometriosis. B. Surgical treatment before IUI may improve outcomes in selected patients. C. IUI is always superior to IVF. D. Endometriosis does not affect fertility outcomes. The answer is B. Surgical treatment before IUI may improve the outcomes in selected patients. 17. The pregnancy rate of IUI in endometriosis is generally A. Higher than unexplained infertility in severe disease, B. Lower in advanced endometriosis due to pelvic damage, C. 0 in all endometriosis patients, D. Independent of disease severity. The answer is D. Lower in advanced endometriosis due to pelvic damage. 18. In women with endometriosis-associated infertility, IVF is usually preferred over IUI when EFI score is high, B. Tubes are normal, C. There is severe disease or failed IUI cycles, D. Patient is less than 30 years old. The answer is C. There is severe disease or failed IUI cycles. Next question. The main rationale for combining ovulation induction with IUI in endometriosis is to suppress ovarian function permanently, B. Increase number of available oocytes and bypass peritoneal factors, C. Prevent menstruation, D. Reduce fibroid size. The answer is B. Increase the number of available oocytes and bypass peritoneal factors. Next question. The last question, which of the following is considered a poor prognostic factor for IUI success in endometriosis? A. Young age, B. Patent tubes, C. Severe endometriosis with distorted pelvic anatomy, D. Good ovarian reserve. The answer is severe endometriosis with distorted pelvic anatomy.
We come to the end of the program. Sivaranjani, please post the scores. Bharati. Happy to say my students have come, got the first and the second ranking. Thank you. So now we are coming to the end of the program. On behalf of Tamil Nadu Federation of OBGYN and Endo Society of India, I should profoundly thank the chairpersons, Dr. Sudha Singh, and the speakers, my dear friend, Dr. Sanjeev Kaur, Dr. Priyanka Dilip Kumar, Dr. Chitra, for having made this event a grand one and a very knowledgeable. I think the people who have attended this would have gained definitely much knowledge. And I also thank Dr. Harshini Jayakumar for having been with me, supporting always in my absence. And I thank everyone and all who have participated. I think you would have learned, at least gained some insight and knowledge about endometriosis. Thank you once again. With this, we come to the end.
Thank you, Dr. Ramani. It was a treat. It was indeed a treat to get, I think, take-home messages, I would say.
Yeah.
Which will help in our practice, certainly. Thank you.
Thank you, sir.
Thank you, Dr. Ramani, for making me a part of this very interesting and knowledgeable session.
Thank you, sir. Thank you.
So we look forward. We look forward.
Yeah, every alternate Tuesdays we are having this program from 4 to
Great.
And this is the 4th module what we have.
Yes.
And subsequently we'll be having I think 6 months course. It is 12 modules we'll be having. No, 12 modules.
12 modules.
Sure.
Thank you.
Sure.
Thank you, sir.
Thank you, Sanjeev sir. Thank you, Ramani ma'am. Thank you, Sudha ma'am. Thank you,
Thank you,
Priya
Harshini.
ma'am.
Bye.
Yes.
Thank you, Chitra ma'am. Thank you.